Hi everyone, I'm Lucia Gambuza with the Eye Care Network. It's Dry Eye Awareness Month, and today we're talking about a topic that sits at the heart of good dry eye care, co-management between optometry and ophthalmology. I'm joined by two guests who actually practice this model together every day. First, Dr. Shareen Greenbaum, an ophthalmologist at Hollywood Eye Institute, and Dr. Amanda Amberg, an optometric physician also at Hollywood Eye Institute. Since the two of you work side by side on patients with dry eye every day, I'm excited to hear about how that collaboration plays out. So let's get into it. Dr. Amberg, let's start with you. What role do optometrists play in the long-term management of patients with dry eye within a co-management model?
So, for the most part, optometrists play the role of the primary eye care providers. Primary eye care, the topic of dry eye falls directly under primary eye care. So, I would call optometrists the gatekeepers. They're doing the initial evaluations, they're doing a lot of the dry eye testing, and they're identifying conditions that require long-term care and management.
Which patients with dry eye are best managed primarily by an optometrist, and what specific clinical findings or characteristics tell you it's time to move toward a collaborative care model?
So, in a collaborative care model, you are taking the time first to do your own assessment, identifying certain conditions such as neurotrophic keratitis, such as autoimmune disease affecting the ocular surface, conditions like that. In those type of situations, it can be managed very well by an optometrist. In the collaborative care model, if a patient has findings that require, I would call surgical intervention, such as conjunctival chalasis or a pterygium, findings that would require surgical intervention, that would be the right time to co-manage care.
And when you decide that, when you do refer a patient with dry eye to Dr. Greenbaum, what information do you find most helpful to include for her?
So, in my own assessment, we're definitely making sure that that is the entirety of the problem and the correct etiology. So, for example, if someone's coming in with excessive tearing and I've identified that there is a finding of chalasis, I'm still going to make sure that that is truly the problem and a probe and irrigation will have been performed before they even see Dr. Greenbaum. So we can assess that it's not just dry eye or an ocular surface pathology alone, and there is nothing else causing that problem before the patient is taken to surgery.
And Dr. Greenbaum, from your side, when a patient comes to you from an optometrist, what do you most want to know going into that visit?
Basically, it's important to understand what testing and treatments have been offered and accepted by the patient in the past. The nice thing about working with Dr. Amberg is we actually have set it up so that our schedules match each other. So while I'm doing surgical consults, she's across the hall doing dry eye care, among other things that she does. And so if there is a patient that she wants my guidance on, or I want her guidance on, we can simply grab each other and go into the exam room and actually have a collaboration right then and there, which I think is something very special, and it makes the patient feel very well taken care of.
That's great. It sounds like you guys have an efficient system in place to be able to access each other quite quickly within the office. So that's great. Dr. Amberg, this question's for both of you, but Dr. Amberg, please start. Can you share an example of a patient whose outcome improved because of a strong optometrist ophthalmologist collaboration?
Sure. So we have a great example, couple examples of patients who've done very well. Some of these patients have actually been long-term patients of Dr. Greenbaum's for many years. They have a lot of trust in her and the care that she's given them. And as time has evolved, technology has evolved, we offer the best technologies in our practice. So I'll give a couple of examples. One patient, a young patient, 49 years old, she has issues in terms of autoimmune, ocular surface inflammation, multiple etiology. She also has evaporative dry eye deficiencies, and we had actually done for her IPL, scleral lenses, and she was stabilized quite nicely. However, we live in Florida and things can change at any time. And, when we design these scleral lenses, they're not meant to be used for 6 months and then be done with them. They're actually meant to be used for several years. And it was a little bit less than a year later, the patient returned for a checkup and she was telling me that something had changed with her scleral lenses and they weren't as comfortable as they had been previously. Living in Florida, the patient had developed a pinguecula, which had been sitting directly where the scleral lens landing zone is. And I just didn't think it was fair to redo an entire scleral lens, a custom lens that the patient had paid for that was previously fitting so comfortably when this pingueculitis now at this stage could be easily resolved with a surgical intervention. And we were able to do that, and the scleral lenses fit beautifully afterward. So that was a great case.
And Dr.
Um,
Greenbaum, please jump in here too if any case comes to mind.
No, I think that, as primarily as a surgeon and having honed my skills into basically being a refractive cataract surgeon, it's important for me to be able to refer some of those primary care cases and some of those dry eye cases to Dr. Amberg. And in fact, she sees all of them. I simply don't have the time in my day to be able to manage those types of issues, along with also meeting new surgical candidates and discussing the intraocular lenses. It's really amazing to have a partner who is able to identify ocular surface disease. Unfortunately, I think it is something that's often missed. And when we talk about the unhappy multifocal patient, it's generally due to ocular surface disease. And so to have somebody in my practice who's my business partner, who cares about the patients and the practice as much as I do, on board with this collaborative approach, I think is very important. She talked about one example, but what I can say is we have patient after patient coming in every day, all day, who is really a miracle story. We see patients who have been referred from other providers in the area, and these are patients who have tried a lot of different prescription drops and different treatments and are just not getting relief. And for them to then see Dr. Amberg and have just an amazing journey in recovery, and then to be able to have a safe and effective surgery, specifically cataract surgery with me, it really completes the journey for the patient. And we're just so proud to have this collaboration. I think it's very unique and it's just an amazing way to practice. And it's really a win-win. It's good for us, it's good for the patients, and we end up with very happy clientele.
I'd like to sort of piggyback off of that. What is advice for ophthalmologists and optometrists who might struggle with that co-management relationship? How did you guys sort of like perfect this system?
we're not competing. We're never competing with each other. I think there has been in the past an idea of, which doctor do I see, optometry versus ophthalmology? And we have a very good relationship. When I came into this practice, I believe Dr. Greenbaum always had a vision for a dry eye center. We did not have the level of technology that we have today. And I believe with our collaborative approach, it's begun to grow and has now become the premier dry eye center in South Florida. But I will say, I think the fact that we are so able to easily communicate, we practice very, very similarly. If I see that she's seen a patient, I'm going to know that everything there is correct, accurate. While you're still doing your own assessment, it definitely helps the process of your examination. And I think it's vice versa. It definitely works that way. And we are so able to get these really, really happy patients, sometimes not even often seen in other practices. And I'm sure many cataract surgeons can attest to this. You have a patient who you've done a beautiful surgery on, beautiful multifocal lenses. The patient comes in, their best corrected visual acuity is 20/20 plano, and the patient's not happy. And they say, no, I still have hazy vision or I have fluctuating vision. And a lot of times that's actually dry eye. And when I had stepped into this practice, there was really a need for pre and post operative dry eye care management prior and after cataract surgery. And just working together in that respect and never competing and always with the team approach has helped significantly. And we just have amazing outcomes. And we can confidently say to every refractive patient that predictably they're going to have excellent outcomes and they're going to have excellent vision after surgery.
To me, it sounds like the bottom line is trust and zero competition. Looking ahead, what opportunities exist for optometrists and ophthalmologists to work more closely together to improve outcomes for patients with dry eye? And Dr. Amberg, why don't you start? And Dr. Greenbaum, feel free to build on it from the surgical side.
Sure.
I think identifying earlier cataracts is a big one in the optometrist community. We definitely need to be recognizing when a patient is having cataract formation, not waiting till the cataract is more advanced. That's a big one. Not waiting to refer out to the surgeon to when the patient is very visually debilitated, because it does make the surgery having a better outcome when you're not having a cataract that is a rock hard cataract. And also offering dry eye care prior to sending them out to a cataract surgeon and really optimizing the cornea for those measurements for cataract surgery and educating the patient on how important those measurements truly are, because the surgery is a one-time surgery in your life, or it's supposed to be. And so it's a lot easier to get the correct measurements and the optimized cornea prior to the surgery. And it gives you such a better outcome when you're really controlling the dry eye, because the post-operative care is so much better for the patient as well.
Yeah, and to add to that, I would say the advice that I would give to the optometric community is to at least broach the subject of dry eye with your patients. Oftentimes, we do get referrals from optometrists or other ophthalmologists, and one challenge that we see is, we're now having to explain to the patient why we need to do extensive testing on the ocular surface, and oftentimes the response that we get back is, "Well, I've been seeing a doctor, and nobody ever told me I have dry eye." Nobody ever told me I have corneal irregularity. And so I think, my advice, especially for the optometric community referring for cataract surgery, would be try to identify those issues and talk to patients about them first. Whether or not you're comfortable treating them, I think it does everybody a service to at least have that conversation with the patient, because then it helps to build the trust when they do see the ophthalmologist. And then when I go ahead and refer to Dr. Amberg for dry eye care. I also think that every member of the practice needs to be on board with diagnosing and treating ocular surface disease prior to any type of ocular surgery or eyelid surgery. I do oculoplastics procedures as well, and it is even more important to identify ocular surface disease prior to doing a lid procedure, which could potentially significantly worsen dry eye. So everybody at the practice has that mindset. Every surgical patient goes through extensive dry eye testing and then whatever treatment plan they need. Everybody needs some level of dry eye care prior to cataract surgery. Some cases are obviously much more severe than others. And I think education and communication and working as a team throughout the whole process really gets to a happy surgeon and a happy patient in the end.
You led perfectly into my next question, and I'd love for you to expand on that. Since dry eye disease can complicate surgical planning, how does identifying and treating dry eye before cataract or refractive surgery change your approach? And what can optometrists do to help prepare those patients beforehand?
It changes my approach in that when I first finished training back in the early 2000s, when I met a patient who was clearly ready for cataract surgery, I wanted to operate that on them the next week. I said, "Okay, you're ready. Let's do it. We'll do your measurements and we'll go." And I think a lot of us surgeons kind of finished training with that mentality because, to be honest with you, back at that time, ocular surface disease and dry eye care were not really taught to any high level or discussed prior to cataract surgery. As residents, we were all very excited to start booking our cases. And we didn't really, and I'll speak for myself, I didn't really take a step back and look at the whole picture, unless it was something obvious going on. And so my approach has completely changed. I'm much more patient now. When I meet a patient who has severe dry eye and who also needs cataract surgery, I'm very comfortable having the conversation with them that this may take a few months. This may be months before we're actually meeting each other on the operating table. And in those few months, you're going to be working with Dr. Amberg. And oftentimes I will bring her into the room to make that initial introduction so she can take a look at the testing that has been done. So that's really how it has changed my approach. I understand the importance of it, much more important than issues with neuroadaptation with multifocal lenses or dysphotopsias. Much more of an issue is ocular surface disease that was not diagnosed prior to surgery.
What advanced or in-office treatments do you offer at the ophthalmology level that optometrists in the community should know are available once they do refer a patient to you?
Well, actually, Dr. Amberg does most of those treatments, so
Okay.
I'm going to let her take over
Yeah.
on that. The surgeries or the surgical intervention that sometimes may need to be done by me, Dr. Amberg did touch on before. For example, if somebody has moderate to severe conjunctival chalasis, that may need cautery or surgery before we're able to really fully improve the ocular surface. If somebody has a large pterygium that would alter my measurements prior to cataract surgery, I would need to remove that before as well. And there are a few other situations like that, but for the most part, Dr. Amberg is really running the dry eye care and the dry eye team. So I will let her discuss some of those treatments that she offers to patients.
Before we offer any treatments to patients, we are always identifying the underlying etiology. We will not prescribe a treatment or offer any treatment until we've seen their meibography, their non-invasive tear breakup time test, their lipid layer, checking tear evaporation time, much more advanced technologies than using a Schirmer test. None of these tests are invasive, and patients also really appreciate when they see their own corneal staining photos because a picture is worth 1,000 words. A lot of our patients, too, because of the time frame that we're in now, are those post-refractive patients, post-LASIK patients, or post-RK patients from many years ago, and they're now ready for cataract surgery, and they actually have a decreased sensation of their corneas due to those refractive procedures, which is a known side effect. And so they actually have not really noticed that they've had much dry eye, but when you're actually showing them the photos or the information, that does definitely help their understanding. After we do our extensive testing and explanation, then when we see what underlying issues are, the right treatments are selected for the patient. And what we have also found is it is never just one thing or just try this. We actually guide the patients to what they need. So we're telling them exactly what they need. Some of those things would involve IPL, intense pulse light therapy, to help regenerate meibomian gland function. Radio frequency is known for many years to help increase meibomian oil production. Dynamic muscle stimulation that we use around the lower eyelids, that would be for lid positioning and blink response. Other options that we offer are the iLux. So we do that using thermal pulsation, and manual expressions are another option for meibomian oil deficiency. And some other treatment options in terms of when we are really dealing with inflammatory conditions, we find that serum tears are very, very helpful as a primary short and long-term option for these patients for surgery prior to and after. Another option, always as an adjunctive therapy, we consider punctal plugs. In our office, we do not consider punctal plugs a primary method. It's always adjunctive because a punctal plug only will really address tear film height or tear evaporation, but we really like to address the underlying cause. Whenever we're dealing with more of these severe pathological keratitis issues, then you would be introducing amniotic membrane grafts. So we do a significant amount of those. Once other therapies have been tried, that's definitely a therapy that we use as well, and that definitely helps optimize the cornea prior to surgery. Down here, we also have a lot of patients with allergic conditions as well, living in South Florida, and a lot of Demodex. And we have found that patients prefer treating Demodex and some of these allergic conditions as well with a Blefex, which is a very quick and effective in-office treatment that removes Demodex and really helps with blepharitis and also for ocular surface disease inflammations as well.
Thank you for expanding on that, Dr. Amberg. This has been a great snapshot of what real OD-MD collaboration looks like on dry eye care. And thank you both, Dr. Greenbaum and Dr. Amberg, for sharing your perspectives today.
Thank you very much.
Thank you.
For all the latest news and up-to-date content for Dry Eye Awareness Month, visit optometrytimes.com and ophthalmologytimes.com. I'm Lucia Gambuza with the Eye Care Network. Thanks for watching.